So Dr. Payal, you have to finish in 7 minutes.
Okay. So my talk is on when managing Descemet's detachment landed up into other problems. I'll go really fast. So we all know what is Descemet detachment, and it is a potential vision threatening complication. Most common cause is a post-cataract surgery, though other surgeries can also lead to it. Risk factors include advanced stage, pre-existing fugues, hard cataracts, and some surgical factors like prolonged surgical time, trauma with the blunt surgical instruments, phacoprobes, etc. So it is detected by slit lamp examination and AIOC2023 and management. Some Descements, like with small detachments or with planar and non-scrolled edges, resolve spontaneously. For larger, we need to do surgical descemetopexy. Others, we can also do a gas tamponade, suture fixation, descematotomy, interface drainage, and keratoplasty. So I'll discuss one case with us, a case with DMD post-cataract surgery. So a 46-year-old male underwent right eye cataract surgery elsewhere, reported to us with complaints of diminution of vision with hazy view after the cataract surgery. He was on topical medications, but there was no improvement in the vision. So on examination, in his right eye, the vision without glasses was counting finger 1 meter. Anterior segment showed pseudophacus, Descemet detachment in the central and inferior cornea, along with Descemet folds and corneal edema, and IOP was 14. So our management plan was right eye intracameral injection of a C3F8 gas in non-expansile concentration. So we went from 11 o'clock position, that was where the Descemet was attached, and we gave him a bubble. Then post-injection, we followed up the patient's IOP at 1 hour, 2 hour, and 3 hour after the procedure. And his right eye IOP was 16 after 1 hour, 16 after 2 hour, and 15 after the procedure. We gave him topical brimonidine plus timolol, hypersol, moxifloxacin, and 2-tab dimoxstat. But the real trouble started from the very next day when the patient presented to us in emergency early morning with complaints of severe headache, nausea, and pain and redness in right eye. On examination, there was severe conjunctival congestion in the right eye, cornea was hazy, but the Descemet was attached, AC was distended with the gas bubble, pupil was mid-dilated fixed, and the IOP was 56. This was when we realized that the gas bubble has expanded. So now what? First, we tried to manage the patient conservatively with injection mannitol, painkillers, antiemetics, tab acetazolamide, but all in vain. So next, the IOP was still 50. So next, we decided to take out the gas bubble, but very carefully, just to prevent the Descemet to detach again. And here, there is a catch. We made 2 attempts to take out the whole bubble. And in this procedure, we missed one small thing, that a small bubble went into the posterior chamber behind the iris. We can see the gas bubble in the anterior, in the slit lamp photograph. And in the subsequent follow-ups in the week, the patient presented to us with slightly improved vision, that is 6/60, but the IOP was still on the higher side. It was around 26. And slit lamp examination showed corneal edema, so we see we are underestimating the IOP. Descemet was attached. AC was almost nil nasally, very, very shallow in the center, and temporally, there was iris stuck to the posterior surface of cornea, as visible on the slit lamp image, the UBM, and the anterior segment OCT. So the last surgical procedure we had to do was to remove the stuck out iris from the posterior surface of cornea and to do a PI. So first we tried to remove the stuck out iris from the cornea with the help of visco expression with the visco cannula, followed by iris repositor. And when we could remove all the iris and we ensured that now the angle has become deeper, then we went for a surgical PI superiorly. So the PI is visible superiorly. Now we did visco washing and finally closed the wounds. Next day, the vision in right eye was 6/36, IOP has come down to 12, anterior segment examination on slit lamp. Cornea had slight edema, but the Descemet was attached. AC has become deep. We can see in the slit lamp photograph. The PI was patent. Pupil was round and mid-dilated. And over the next follow-ups over 3 months, the unaided visual acuity improved to 6/12 partial, with the Descemet folds have settled, and BCVA was 6/9. Cornea has become clear. Descemet was attached. AC was formed and deep. PI was patent. Pupil was round, reacting to light, and there was pseudofocus. IOP was 12. These are the post-op pictures after 3 months. Now, literature says that why do complications occur with isoexpansile gas intracamerally? Either the gas is loaded in a higher concentration. I think in our case, this was a mistake we did. We gave a 15% concentration of the gas, so the gas expanded. And when the volume of gas injected is more than the volume of the AC. Other complications other than the gas expansion includes the pupillary glaucoma, which is treated by peripheral iridectomy, subconjunctival or subtenon bleb, and malignant glaucoma. This is an important and serious complication, needs to be taken into seriously, and it is managed by lens aspiration with anterior vitrectomy. Also, there is some literature has noted delayed post-op migration of gas bubble in the pre-Descemet space, leading to redetachment of Descemet membrane again. So as a take-home message, I would say any expansile gas injected into AC should be given in isoexpansile concentration and in optimal volume only. Signs of gas bubble expansion should be identified, and gas bubble should be removed as soon as possible. Migration of the gas bubble into pre-Descemet, posterior chamber, subconjunctival space, etc. should be meticulously washed out and removed as soon as detected. And in all these cases, a surgical or a laser PI should always be done prophylactically. Thank you. I think I've
Yes.
I've been
you.
fast and
So committed. So I just want
finished
to
my talk.
add one thing. I think Varthi ma'am knows the center where I'm working. There's a huge bulk of cataract surgery. So there's a free gift. We are getting lots of DMD. So what I want to add that being a disc surgeon. So whenever you give the C3F8, specifically I saw the video. I don't know the same patient or not. Don't enter whole thing full by the C3F8. This is expansile gas. So whatever we are using, if we are using the C3F8 just like here DMD or for the even also bad your disc surgery or DMEC, then we are giving the at least 2/3 of the, because we know invariably it will be prolapse. And when if it is for the C3F8 for the DMD, I personally prefer inferior PI. Because you don't want to be next whatever you saw the next morning or midnight the call from the patient. So it does no harm for you being inferior PI. Then everything is very much predictable. Or if you have a expansion or something, so you need not again enter by your side ports. You simply the 30 gauge needle, you just release the 50% gas. So automatically instant you can see after 3-4 hours it attach and it will never come out. So it will be solve your purpose.
So actually, we have treated many DMDs and all were without complications. This was a special
No,
case.
we are using
went
the
into a series
14%.
of complications.
Yeah, and this is
By
a,
presenting.
very specific. This is your pupillary glaucoma. Like that's it.
Yeah.
Thank you.
That's a
sir.
nice
Very good.
presentation.
Good.